I'm going to go ahead and get started with introducing our first awesome lecturer. So I have the privilege of introducing Dr. Rhonda Watkins. Dr. Watkins is a primary care sports medicine doctor. As a former track and field Olympian, she draws on her personal experiences from athletic training and injuries to shape the care that she provides. She treats children and young adults with a wide range of musculoskeletal conditions. Her areas of particular interest include injury prevention, fractures, bone health, and running injuries. Dr. Watkins' research interests include injury prevention, gait retraining, and the impact of social media on athletes. Originally from Trinidad and Tobago, Watkins earned her medical degree at St. George University School of Medicine in Grenada. She completed a residency in pediatrics at UCSF and a fellowship in primary care sports medicine at Boston Children's. During her fellowship, she served as team doctor for Northeastern University and Middlesex School and consulting doctor for Boston Ballet School. She also provided medical coverage for many local events, including the New Balance Indoor Grand Prix, Boston Ballet's The Nutcracker, the BAA Half Marathon, and pre-participation physical exams at Emmanuel College. She has a master's degree in public health from UCLA. As an athlete, Dr. Watkins had an extraordinary career in track and field. She was a long jumper and a high jumper on UCLA's track and field team, becoming an NCAA champion and several-time All-American. As a member of Trinidad and Tobago's national athletic team, she competed in multiple international track and field meets, including the 2008 Summer Olympics. She holds her team's national record for the long jump. And a fun fact, in case none of that was enough for you, she likes to bake, because when she's not going fast, she goes slow. And her favorite is brown butter chocolate chip pecan cookies. So she didn't bring any for us, which I'm a little disappointed in. But so please join me in welcoming Dr. Rhonda Watkins.
Good morning. Thank you for that introduction. Next time I'll remember to bring some cookies. Thank you guys for joining me so early to talk about concussions. We'll get right started. Let me just make sure I can figure this out. I have no disclosures. And it's my goal for you today that you'll be able to recognize sports-related concussions and any red flags, as well as apply the updated assessment tools that we have at our disposal for concussion management. I want you to be able to implement early active management and return to play. And then I'll give you hopefully some talking points for your patients and families to differentiate myths from evidence, as well as some of the newer preventive strategies that are around. Okay, so concussions, we continue to talk about them. They continue to be in the media in 2025. They're a part of, they've been reported in female athletes, male athletes, professionals, athletes, youth athletes, in contact and even non-contact sports. So typically like track, we don't think of people getting concussions from it, but it's reported and it's being publicized in the media. So it's something that we need to be comfortable talking about and treating. And then also, of course, in our youth athletes, not only professional or recreational athletes. But what's really new about it? So every couple of years, an international group of professionals, experts in concussions meet to generate a consensus statement to help us guide our management. And the most recent meeting was actually in 2022. And that generated a consensus statement, a new one for us in 2023. That's the 6th version of it. And so my talk will largely focus on that and the changes that came out of that. Some of the things highlighted in that are these updated tools, retirement from sport, and then some discussion on concussion in parasport. I won't talk about that today in the interest of time. As you know, there's a lot of talk about CTE, and that's continued, as well as these emerging prevention techniques. So the statement is available for you to review, but to get us started, I want you to meet Kyle. He is an 18-year-old soccer player who took multiple hits during a game 2 days ago, well, a tournament, so multiple games. He had no loss of consciousness or symptoms on that day, but he comes to you now presenting of dizziness, sadness, and nausea. Is this a concussion? Yeah. So how might we navigate, Kyle? So that we're going to go through that in my presentation today. But first, I want to ask, which of the following is true about concussion? So we'll just do show of hands, but A is loss of consciousness is required. B, imaging usually confirms the diagnosis. C, it's primarily a functional brain injury. And D, symptoms must appear immediately. And so who thinks A? Oh, if it's in there, great. You can use it on the app. And then are you guys gonna generate the results? Perfect. Okay, so everybody has a clear understanding that it's a functional injury. I think one thing that is confusing for people is sometimes kids come in and they don't have symptoms right away and they come a few days later and you're like, well, is this a concussion or not? So let's look at the definition. So it's a traumatic brain injury, usually termed a mild TBI, that results from a hit to the head or anywhere in the body that transmits a force abnormally to the brain. It's functional, not structural, so you won't see any changes on imaging. And it results usually in rapid onset of some kind of neurological change, some neurological cascade of symptoms, but it does not have to be immediate. It could be immediate or evolve over hours, minutes, or even a couple of days. What we know about the pathophysiology is really from animal models, but we think the concussive event causes some changes in axon neurotransmission, causes some breaking and stretching, leaking of the ion channels, and that leaking impairs neurotransmitter transmission at a time where you really need to do that, and there's lower energy supply and blood flow to the brain. So the neurons essentially become out of balance, and your neurons are the wiring of your brain. So the wiring changes, but the structure so much it remains the same. And the wiring is what really impacts the function, how we look, how we feel. We continue to talk about concussions because they are common, particularly the sports-related ones. It's estimated that about 3.8 million sports-related concussions occur annually in the US, and 1.9 of those tend to occur in youth athletes. We think that happens because they have high volumes of sports and they still have developing brains. We know that female athletes have higher rates in comparable sports compared to males. And then most athletes will recover by 4 weeks, but some of them, about 20% of them, will have prolonged recovery. And these are the ones that additional tools for management and referral resources would be helpful for. Even in 2025, underreporting is still an issue, so let's look at why that might be. There are disparities in reporting across cultural groups and people in sort of marginal or outlying communities. We know that's particularly true for Black athletes. They're less likely to present to the emergency room for concussion, for example. And we're not sure exactly why. It might be a combination of things, cultural expectations, fear of losing their spot, et cetera. The gender-based inequities, we see female athletes actually are more commonly will have concussions, and they take longer to recover typically. We think that has to do with decreased neck strength compared to males, and some other hormonal imbalances, but they actually really received less screenings and fewer follow-ups than their male counterparts. And some of that might be us, like our own implicit biases in when we treat athletes. And so it's important to be aware of these differences and change our practices accordingly to support the athletes we know that we might be missing in diagnosing. There's also differences in how we manage it. We know that access to a trained professional really dictates safe and effective management of concussions, particularly athletic trainers or certified athletic trainers, and access to athletic trainers it varies, particularly for our youth athletes. Some schools have it, some don't. Most youth recreational teams don't have one. And so we're already putting them at sort of a disadvantage in terms of management and guidance with their return to play protocol oversights. If athletes that are in low resource schools or communities also will have less access to referrals, and the referrals become really important for the athletes that have prolonged symptoms. And then we know that there are some insurance-based limitations as well to access. Okay, so common concussion symptoms, you may be familiar with them. I like to think of them in these buckets of somatic, so like headache, nausea, photophobia, phonophobia, cognitive symptoms, emotional ones. I think sometimes we overlook that because, of course, there's also a high prevalence of emotional burdens in general. But people can see just emotional changes. Sleep changes also important, and then balance and vestibular changes. So red flag symptoms are symptoms that you should be immediately removing an athlete for if they exhibit these signs on the field. And you should be considering perhaps other diagnoses as well, or ruling them out. I'm not going to read them to you, but they're here for you to be aware of. So let's get into the new tools. So the sixth consensus statement provides us with an updated SCAT, or Sport Concussion Assessment tool. This is a sideline tool. The SCAT 6 is what we should be using now. So if you're still using 5, adjust to 6. We know now, based on this consensus statement, that this tool is mostly effective for up to 72 hours. After that, the validity is not as good, so you should not really be using it beyond that time frame. And that was a practice change for me post this consensus release. So let's get into the different parts of it now. I'm gonna have to move because I can't see my notes here. And so the stars on the PowerPoint are intended to highlight new things from the SCAT 5, so pay attention to those. The first new thing sort of in the SCAT assessment is the observable signs section for things that happen on the field has been expanded. So for those times where you see something happen, you're like, is it concussion or not? You have a little more tools to rule that in or rule in concern for it. And so it includes things like tonic posturing or a fall without protection, for example. If they have any like ataxia or balance or coordination issues, we know that's very sensitive right after. You should be more concerned for a concussion in those cases. It also has a new coordination and ocular screen that is intended to be done on the sideline. And then it continues to have like the Maddox questions for awareness, like what part of the game are in, who's up, things like that. The red flag section, also pay attention to, has a couple additional new things. The athlete background section has been updated to include some questions about past medical history, things that we know that put you at risk for increased or prolonged concussion symptoms. The symptom evaluation score is still 21 symptoms. We acknowledge that there are other symptoms that people will present with that might be suspicious for a concussion, but these tend to be the most common ones. They've eliminated the athlete readback component of that, so they just fill it out. And I think perhaps one of the bigger changes is that they've changed the immediate memory recall word list from a 5 list to a 10 list, because the thought is that there was some ceiling effect occurring with athletes being able to memorize the 5 words. And so we wanted to make it a little more challenging. You still have a concentration assessment with the digit in reverse recall. And then it includes still the best testing, so modified best testing, so balance testing. I think this is an important screen, and you'll see it again in the in-office assessment. So I wanted to go through it in a little more detail. So it's a double leg stance, a tandem stance, and a single leg stance. For the tandem stance, you're checking balance, hands on your hips, eyes closed, with the non-dominant leg behind. And then for the single leg stance, you're standing on the non-dominant leg, which is a leg like if they were to go kick a ball, that's their dominant leg, so the opposite leg. Hands on your eyes, hands on your hips, eyes closed, and you're checking for these errors on the side here over 20 seconds. And you count or tally the amount of errors. So the maximum amount of errors is 10. If they're struggling with double, you don't really need to go to tandem and single, because you know they'll have more than 10 errors. The timed tandem gait is also a newer addition here. What it shows is, what it is you check their ability to walk tandemly, so heel toe over a 3 feet long line, and you time that over 3 trials, and you sort of get an average. So of course, with a lot of these assessment tools, it's helpful to have a baseline, but sometimes you don't. In those cases, they recommend like serial testing. So if you remove someone from the sideline for concern for concussion and you're doing a scat, you want to administer it maybe at halftime again, and then at the end of the game, and you could sort of compare the scores in that sense. And then it wraps up with delayed recall, again with a 10-word list recall. So that's a big change from prior. The consensus statement also gave us updated child scat, and this is to be used for kids 8 to 12. It includes a child-friendly symptom list, as well as the parent or caregiver record of observable signs as well. And so to summarize the SCAT, 6 sort of updated changes. Big one is no longer 5 words, now 10 words. You have more observable signs to help you in your diagnosis. The time tandem gait should also be a part of your assessment. So now we'll move on to the in-office assessment. This SCOT is meant to be used in clinic first up to 72 hours, from 72 hours after the injury to weeks post-injury, and you could use it again to track progress over time. It's a structural, multi-noded way to evaluate a concussion patient. It has many parts, and we'll go through it. So time sometimes is the biggest limiting factor for doing this, but at least you have this at your disposal for a structural way to follow, diagnose, and help manage your concussion patients. So let's look at the SCOT a little closer. It includes a past medical history of concussions or other neurological learning disorders or psychiatric disorders, and then a symptom inventory as well. A big addition to it is the use of the orthostatic vital signs as a part of your formal assessment. So you want to check blood pressure, supine, and then standing, and look for changes. And in the SCOT, the way they've organized it, as you look through that protocol, you'll see there are recommended protocols or steps, and then there are some that are optional. So I'll try to highlight those. And the orthostatic vital signs is one that they have recommended that you include. A C-sign assessment as well. Your normal neuro exam, cranial nerves, etc. And then the balance testing that we went through again. The supplement to this code has some normative values, which could be helpful in cases where you've never checked their balance or their time tandem gait before. So you could use that in your interpretation of the SCOT results for kids that don't have a baseline. And I provided that on the side here. This one is optional. It's a dual task gait, which we typically do in our office. So in addition to doing the tandem gait, you're asking them either to recite the months in reverse, months of the year in reverse, or spell words backwards, etc. You could choose which one you'd like to do. And then it includes a recommended assessment of vestibulo-ocular function with the modified VOMS testing. So how many of you have heard of the VOMS testing? And then how many people actually use it in your assessment of concussion patients? Okay, so people are familiar with it, but not actually using it. And so I hope after my talk today, I could make a case to encourage you to use it. Now you don't have to do the full VOMS, so it'll take less time. It's modified to only include the smooth pursuits. So what VOMS is testing is smooth pursuits. They do look at my finger, follow it, side, side, up, down, twice in each direction. And then saccades, so it used to be both vertical and horizontal. Now the data shows that just doing horizontal is effective, so looking from one finger to the next. And what you're really looking for is symptom exacerbation. So you can ask them for, did your headaches increase, and what scale is it on now? And you compare that to the baseline concussion symptom score they had before. And then it does your vestibulo-ocular reflex. So you're looking at a point. So usually we do like a tongue depressor with an X on it. Their recommendations for the specific font size is supposed to be 14 point. And they should focus on it and move their head side to side. And again, looking for symptom exacerbation. And it tells you, like, repeat it 10 times. So they've actually abbreviated it a fair amount. So timing-wise, it shouldn't feel like such a huge addition to your concussion assessment. And then the last part is the visual motor sensitivity screen. You stick your thumb out, look at the tip, and you move side to side, and looking for symptom exacerbation. So the VOMS testing is highly predictive of prolonged recovery when abnormal. So I think doing it in some form, even if you only do it at the first evaluation in clinic, is helpful. So this is a diagram from the NATA that explains the VOMS in a little more detail. There's also a QR code to like a YouTube video here that goes through it in detail. So familiarize yourself with it. And then remember that now you don't need to do both horizontal and vertical and the convergence testing. So the data that supports the VOMS screening is pretty well established, and it's not new. And so I think we've had a lot of years suggesting that this is helpful in management. And I think as a primary care provider, now that it's been sort of abbreviated and shortened, it's a useful tool you can add to your assessment that could help you in identifying kids that will struggle or athletes that will struggle with prolonged recovery or that need referrals. If they have any one item that produces a symptom score increase of 2 or more, that the probability of being concussed is at least 46%. So for those people that come in and you're like, it's confusing, they had no symptoms or they had symptoms much later on, using this can be one more tool in your wheel kit to help support the diagnosis. Because concussion continues to remain a clinical diagnosis. We don't have any one test. So the more things we can do objectively that are backed in sound evidence to support the diagnosis, the more confident we can feel in our diagnosis. The VOR and the visual motor sensitivity tests, those particularly are very accurate for identifying patients with concussions from controls in the literature. There are also some optional anxiety, depression, and sleep screens that were added to the in-office assessment that we've adopted in our clinic that has been helpful in identifying people that might be at risk for prolonged recovery as well. And so these are abbreviated anxiety and depression screens. If they have high scores on it, then you could do a more formal or thorough evaluation. And they have some screening tools available in the supplement for the SCOTE. Okay, so when should activity start? That was a big takeaway from the updated consensus statement as well. Should it begin immediately? Should it begin after 24 hours of relative rest? Or only after resolution of symptoms or after 2 weeks? So you can answer in the app. Thank you for your participation. Okay, so most people feel only or after 24 to 48 hours of relative rest, and then a fair amount after full symptom resolution. So let's look at that. That's an important takeaway from my presentation today. Now we have a good bit of data that tells us that early activity is helpful. So nobody should leave this room still telling their patients that they need to be cocooning or sitting in a dark room. The past consensus statements, some of them did recommend that, but now we know that early exercise, early activity, subthreshold is helpful, and it can start 24 to 48 hours after. There's even some evidence that it could start immediately, and I'll give you the parameters for that. So remember, they can be active. Of course, the mainstay of concussion management remains that you don't want them to get a second hit, right? So they can go be active in their contact sport or full risk sport or a high risk injury, re-injury sport, but they can take a walk. They don't need to just sit and do nothing. And you certainly don't want to wait until full recovery of symptoms, because you might be waiting a long time, particularly in kids that have vestibular or oculomotor dysfunction. That tends to hang around for quite some while. And so you don't want to wait until that resolves completely to get them active. We know activity encourages blood flow to the brain, which is helpful for concussion recovery. And a lot of the recommendation, or this newer recommendation, is based out of studies from Dr. Letty and his group. And this is one of them. This is a randomized control trial that looked at 103 adolescents. And they compared an aerobic exercise group to just a stretching group. And they found that the exercise group recovered much faster, 13 days faster, than the stretching placebo type group. There's also a couple systematic reviews and meta-analyses of exercise versus rest, et cetera, after sport-related concussions. And what they found was that strict rest until symptom recovery is not effective for it, and that light intensity physical activity like walking, that does not exacerbate symptoms significantly, is actually helpful to facilitate recovery. So some of the challenges I have with prescribing activity for my athletes post-concussions is they want to know, like, how much can they do, right? And so, of course, we have the return to play to guide that, and we'll get into that next here. But now the consensus statement actually gave you some objective sort of guide to counsel your patients. So they can continue activity if they have symptoms that are mild. And what is mild? So no more than an increase in 2 points on a 0 to 10 scale of symptom severity. And usually you're assessing that already with the screens and the forms that they do and the symptom recall. And so giving them that sort of objective way to manage their symptoms is helpful because a lot of them think they can't have any exacerbation of their symptoms, which we know is not true. It's not necessarily harmful to the brain. And the benefit that they're going to get from the activity is more important. So it's if no more than 2 out of 10 increase and it doesn't cause you to have prolonged symptoms for more than an hour. And so the new concussion consensus statement also gave us updated or more expanded return to play protocol. The red star here again highlights sort of the biggest change. They split the aerobic exercise phase into sort of 2 phases based on heart rate, max, et cetera, and gives some more detailed examples of what you can be doing in each of the phases. This return to play remains something that we want people to complete before full clearance. It tests their ability to tolerate activity. I have people come in all the time that they're now functioning normally in school, work, et cetera, and they haven't done any activity tests, and when they go to do a burpee or run or whatever, they suddenly have return of symptoms. So it's an important part of your management. You shouldn't be clearing anyone without them completing the return to play. And I usually have people stop before the contact practice come back to me so that they can get clearance before they advance to that stage. For my youth athletes, I'm using the CIF return to play protocol, which gives even more specific details on some of the activities and stuff they can be doing at each stage. Ideally, they should go through this under the guidance of an athletic trainer or coach, but as we talked about previously, not everybody has access to that, so the more information, examples you can give them for safe ways to increase their activity, the better. The return to learn strategy is similar. Most kids can return to school after a day or 2. They don't need to have prolonged time off from school, but you want to support them with accommodation. So extra time for testing or no testing or reduce the workload or accommodations for light and noise exposure, et cetera. And so that's where you come in and you're gonna be very helpful in providing letters, et cetera. Some of them need 5 or 4 plans, depending on how long they've been out, et cetera. There's some evidence to suggest that reduced screen time in the first 48 hours is effective, but not after that. So they don't have to stay off their phones and TV, et cetera, video games, things that make them happy beyond that time. And even in the first 48 hours, they can do it as long as it doesn't exacerbate their symptoms. And so I try to think of concussion management as like a dial. You want to mimic normal life for as much as you can, moving the dial towards normal life without going past sort of your symptom threshold exacerbation point. And then usually we're asking them to come back or to be back in school full time if they're a student athlete before we clear them for sports. And so the consensus statement also provides a return to learn progression that you can follow. So a lot of the screening tools asks about past medical history, et cetera. It is for this reason, because we know that there are specific factors that increase your recovery or increase your recovery time from a concussion, like migraines, pre-existing mental health stuff, sleep disturbances. We know also VOMS dysfunction is an important predictor of prolonged recovery. And then we talked about the younger athletes. And some studies have shown they tend to have a slower recovery, and then the females. So let's get a little into treatment. So the consensus statement had some updated evidence on rehab. We know that early physical therapy can improve the outcomes of patients with concussions. In a trial of over 200 adults, they found that the early PT group recorded less symptoms and had quicker recovery and regained their balance faster compared to those that were initiated in physical therapy later. Vestibular rehab is helpful. The timing is a little uncertain. If you look at like the AAP recommendation for youth concussions, they recommend about 10 days, but we know that, like, if you get that started earlier, that is also associated with shorter recovery times. And so you should be referring sooner rather than later. I think persisting symptoms for more than 4 weeks, definitely. If they have any of those risk factors for prolonged recovery, and then if you're doing your VOMs or balance testing and they have some dysfunction, you know that they're going to be at risk. And so, and you want to get them to the referrals, the specialty PT sooner rather than later. So you should be referring those. So let's look at prevention strategies now. There are quite a few prevention strategies that came out of the most recent consensus statement. A lot of them were rooted in youth sports literature, but they are, I think, promising for future studies, and we'll see if we can apply them across all our athletes that sustain sports-related concussions, I think, in the future years. And so we know that rule changes that limit contact in youth sports can help prevent concussions. Neck strengthening. The thought is if you have strong neck muscles, it has the capacity to absorb more force during a collision, which could lead to less of that force transmitting to the brain. Technique training is important, like proper heading, and head-up tackling, et cetera. Limiting contact in practice. So there's some studies talking about limiting the amount of contact tackles, et cetera, in practice or preseason work, and how that has reduced concussion, the incidence of concussions. Disallowing body checking, particularly in youth ice hockey. We have some good data to support that. And then mouth guard use in youth ice hockey. So traditionally we thought of mouth guards as just effective for preventing dental and oral injuries, but there's some evidence that for youth ice hockey, it's helpful for reducing concussions as well. And so we'll have to see if that will be applicable to other sports and populations in the future. And then neuromuscular warm-up programs. So we talk about that a lot in prevention for things like ACLs, et cetera. And we also know now that it's helpful in rugby athletes for concussion prevention. So what about the emergent innovations? So how many of you get people coming to you asking about any of these pictured on the screen for their reducing their concussion risk? Okay, so a fair amount, right? And so there are loads now. I think some of the more common ones are like the Q collar, which is pictured here at the top, the Chargers player. The thought around that is that it applies like a light pressure to the jugular veins, and this causes a slight increase in the blood volume in the brain. And so the thought is if there is more blood volume inside the head, that helps reduce the brain's movement in a concussive force or blow, which decreases your risk of concussion. And there are a couple of studies that supports it. This is made, it's expensive, it costs $200. There have not really been reported any adverse effects of it. And so, but I see your face, the thought of like compressing the vein here, I guess. But I have people ask me about this probably weekly because they are searching for something to help reduce their kids' concussion risk. And we don't have enough evidence to report or recommend it routinely, but it is something that's available. And as of right now, we don't have a lot of evidence saying don't use it either. So I tell people they can use it if the cost-benefit profile makes sense to them and their family. The Guardian cap is the sort of squishy helmet cover that reduces the blow or the impact on a concussion, or that's their purported claim, yeah. And so this mostly has been used in NFL, and they have a lot of studies suggesting that it reduces concussions. They've reported it reduced their concussions in preseasons over the last 2 years by 50%. But there have been studies in the collegiate population and high school populations that couldn't reproduce that. So I don't know what they're doing differently in the NFL, but we don't have enough data to support or recommend consistent use of the Guardian cap either. There's been a lot of like helmet technology. So we think of helmets as reducing your fracture risk, but now they're doing things like improving fit. There's like a rating for fit and quality of helmets that you can use that NFL puts out. So there's not all helmets essentially are created equally. And so you can provide that to your patients and they can decide if it's worth the up cost, et cetera. But important fit is also important. There is a lot of talk now also about biomarkers, so markers in the blood. And maybe one day we'll get to a point where we can use a blood test to diagnose concussions. Multiple are being tested. I listed a few here. But as of right now, the window of change extends beyond recovery, and we don't know what that means. So like it will be elevated right after, but it stays elevated sometimes even after people have recovered. Does that mean they're still concussed, or we should still be holding them out, et cetera? And then some sensor work with the helmets as well. People are using it, but they've seen varied like levels of hit intensity that can cause a concussion, sometimes really low, which is surprising. So we don't have any one standard to say this is helpful or effective for concussion diagnosis. So remember Kyle from the beginning. He actually has a history of multiple concussions. He's had 4 in the last 3 years, 2 this season, and he's had prolonged symptoms. He also has comorbidities. And so which factor would be most important when deciding if he should retire? Perfect. So lengthening recovery and decreasing injury threshold. Some people still think the total number of concussions, so we'll get into that next. Okay, so there's no absolute number of concussions that should make you feel like you need to tell someone they need to sit out of their sport. The things you want to consider, though, are the patterns of injuries. Is it happening more frequently? Are they having longer recovery, more symptoms from it? Are they not fully recovering in between each one? And usually you want to use that in the context of their goals. If their goal is to be a professional NFL player, a soccer player, or whatever, and this is what is important to them, they don't care if you say 5, 6, 10, whatever. They want to understand why, and they want to be a part of that decision making. And often it varies between the parent and the child. A lot of the parents don't want them to continue, but the child does, et cetera. So it's usually some shared decision making. And I think that I've seen a lot of referrals just for that purpose. For me, I usually say if someone's had 4 or more, it's an appropriate time to pause and have this discussion. But I'm not saying if you have 4, you have to stop. So the number is not what you should be using. CTE, you're going to get questions about this because it's all over the media. I tried to highlight, so chronic traumatic encephalopathy. So it's a post-mortem diagnosis where you see accumulation of like tau proteins in the brain and neurofibrillary like tangles that leads to like dementia, mental health problems, differences in impulse control, etc. Now, this became popular with the movie with Will Smith a couple of years back, and sort of has never really left the media. And what they found is that they're seeing it, or they've seen it in a couple of NFL athletes after that, when they do the postmortem analysis of their brain. But we still don't have anything to diagnose it while someone's alive. And that's, we have to tell people that. So you can't come to me and say I have CTE, because I have no way of confirming that, right? And so I think as you approach people's concerns about it, you want to try to stay rooted in the facts that we do have, which is that, yes, we've seen it in people that have done professional sport or have had repetitive head impacts, but it's not necessarily from one isolated concussion. All athletes in contact sports don't have to develop this, and it shouldn't be something that they carry with themselves. I've seen it cause a fair amount of anxiety in youth athletes, et cetera. And so I think how you comfort, guide the discussion is important. So some of these myths here, though, are common things people come in with. I've tried to give you a fact for you to use to counter that. But let's look a little about the evidence about the sort of long-term effect of repetitive head impacts. And so the consensus statement sort of summarizes the most recent literature on that. And what they've showed is that former male amateur athletes are not at increased risk for cognitive impairment. So amateur people, which probably is the majority of people that we'll be treating. So you can reassure them that unless you've been, playing in the NFL or MLS or whatever, for years, like, this is not a worry that you should carry. And then there is evidence, that there are greater mortality rates from neurological diseases like dementia and ALS in former professional football players as well as soccer players. But the studies on this have not really examined like other comorbidities, other things that increase your risk for these diseases. And so we can't use them as like causal studies. So we can't say if you do that, you're going to get this for sure. But this, if you're treating professional athletes, it's a reasonable discussion to have, and you could share this data, but acknowledge that we don't yet have causal data. So when you're talking to families about CTE and these long-term fears, I think it's important to highlight the amateur versus professional difference that we see in the literature right now. Acknowledge that might change, right? Like, we're still studying it, and the consensus statement actually talks about a clinical diagnosis that's being sort of developed, and so we might hear more about that and have more tools to help you with this concern. But for right now, unless you've been in the NFL or some professional league for 5 years or more, you don't really need to be worrying about this. So to wrap up, I'm just gonna go over a couple other concussion myths. So the first is you can return to play as soon as you feel okay after a concussion. Is that true or false? Right, so you can return to play. We talked about some active management with play, and then the parameters within which people should stay, no more than 2 points, increase in their symptoms, and no symptoms lasting more than an hour. But it is the law of California that they can't return to full play before 7 days from diagnosis. So sometimes they come to you and you're the first person diagnosing them. You should not be clearing them on that day. They have to complete this return to play protocol, which usually takes about 7 days. You go through each step in about 24 hours. And so it's helpful to have this law, because you're not doing it based on your opinion. I'm following the law, and I can't clear you right now. Come back in a week.
Can I clarify that?
Yeah.
A lot of my student athletes, their trainer takes them out, and like the school has sort of a mandatory 2-week wait protocol. But if they want to return to play earlier, they'll often come to the doctor and say, hey, can I return at day 10?
Yeah.
Has their trainer diagnosed them with the concussion, like in terms of the letter of the law?
Yeah, the trainer, if it's a certified athletic trainer, we can't, so the trainer cannot go against basically what you say as the physician, but they can diagnose them, but it does not count in like the context of the law. It has to be like a trained professional, usually like an MD or D or whatever, that's making the diagnosis.
Okay. It's gonna be unhappy.
Yeah, but like if it's already 10 days, right? And then, they're not having symptoms and the trainer has diagnosed them and they've already gone through the return to play protocol, then they're within sort of the law because they've finished the return to play protocol. That's the main thing with the law is that you want them to go through the return to play protocol before clearance.
Okay, I just wanted to make sure, like, oftentimes people come to me after the week or 10 days or 2 weeks, and I've never diagnosed them, and maybe only somebody on the sidelines has. I don't really know their qualifications, and I don't want to
Right.
let somebody out for another week if they're fully recovered.
So a lot of times the athletic trainer works with a sideline MD also. So if they've had a diagnosis from the sideline and they've been managed by an athletic trainer, I usually count that as counting. And because we have real data that says that if they have access to an athletic trainer, that is associated with better management. So I don't think we can discount it. It gets a little complicated in California with the certifications and stuff for athletic trainers, but I count it.
Okay. Judgment call, okay.
And then, is it okay to keep playing as long as you don't get hit again? Yeah, no, right? And so we also have good data that continued exertion of any form after a concussion, even if they don't have a second hit, is associated with prolonged recovery. So I always try to reason with them that if you sit out now, you will probably get back to your game sooner than if you continue playing right now. It's not worth this couple minutes or the last half or whatever in this game. So when in doubt, you should sit them out, take their helmet if you need to. So to wrap up, the key takeaways is concussion remains a clinical diagnosis. You should sit them out if you're not sure and use one of these new updated multimodal assessments to clear them. And then now I hope you know that early aerobic activity, subsymptom threshold, is effective and you should be recommending it. And then I hope you feel empowered to use at least the modified VOMS testing to help in diagnosis and predict people that need early referral because they're at risk for prolonged recovery. And then I hope you have some sense of the newer prevention strategies across sports-related concussions. I didn't talk too much about like criteria I use for clearance, but usually I say at least no symptoms for at least a week. They have to be caught up in school or have a plan for how they're going to do that. So basically, if you're still needing accommodations for school, I can't clear you for your sport. They should have completed the return to play protocol without return of symptoms. The testing that I do in office, part of the school assessment, et cetera, should all be normal, including the VOMS testing. And then they should feel back to 100%, whatever that is for them, because we acknowledge that many of them will have other pre-existing comorbidities. If they're at baseline with their mood dysfunction, sleep dysfunction, et cetera, that's not a reason to hold them out. So these are some of my references, and we'll open it up for questions.
I work in an urgent care, and I see a lot of kids 1 to 4 days after a concussion. They can't get in with their regular doctor, so their parents bring them to me. And they say, my kid got a concussion in whatever sport the day before yesterday, and they're still laying there like a dead thing, and they won't eat because they're nauseated, and they won't do anything. And I look, and the kid's laying face down on the exam table, looking like a dead thing. And I say, let's have you sit up, let me look at your eyes. And the kid doesn't want to do anything. They won't hardly open their eyes. And I say, how bad's your headache? And they say, oh my God, I can't stand this. And so I turn to the parent and I say, look, I don't know this is just a concussion. You have to go to the ER and get a CAT scan to make sure it's nothing worse. And at that point, the parents say, but it's just a concussion. They told me that, when it happened, it's just a concussion. Just tell me my kid is okay. And I say, I can't. They need a CAT scan because it could be something way worse. How do you approach this discussion? I'm finding a lot of argument because they don't want to go to the ER,
Yeah, well, first I'll say not everybody needs to go to the ER, right? And so if you're dealing with youth athletes, there are the PCARN guidelines that can use to help you decide if a CT is useful or if you send them to the ED, if they will actually even do a CT. I think if they're not having the red flag symptoms you talk about, we know, especially if they're 4 days post their concussive event, the risk of having like a brain bleed, et cetera, the things we're looking for on CT is low, like really low. And there are studies on that, I think it's like 0.0 something. It's really, really low, especially the further out they go. So for you, if you're seeing them later on, you could use that to guide your decision. You could still use the PCARN guidelines. You remind them that we're ruling out other things. It doesn't mean that you don't have a concussion, but you could have a concussion and something else if you decide they do need to go to the emergency room. And I think that they should be following up with their primary care provider. You shouldn't be carrying the burden of clearing them, not knowing them, et cetera.
Hello, thank you for your presentation. Just a question in terms of kids not being able to go fully back to play, but then they can do aerobic activity. And I know they'll want to be pushing how intense can that be? Can you give me some safe examples? Walking, running, biking, or what do you think?
Yeah, so walking around the block or around the house or whatever is usually where I have people start. And then it depends on like what symptoms they're having, right? If you know they're showing signs of vestibular ocular dysfunction, like going on a jog where your head is bouncing up and down is going to be hard for them. It'll cause symptom exacerbation. And that's where like doing the VOMS testing is helpful. So you might say then after you're walking, you don't start jogging, you do stationary bike. You keep your head at one level, and you start with a couple minutes, and then you build up from there. You wouldn't go to things like burpees, up down things, even lifting. We think of as non-contact, lower risk. But if they're doing hand cleans and snatches and stuff, and they have vestibular ocular dysfunction, that's not something that you would recommend for them. Both the CIF return to play and the Amsterdam consensus statement return to play has examples of activities. And then there are some sport-specific return to play protocols published from like Canadian data that can be helpful too. Like, so for your chair athlete, like what does that mean for them? Because they're probably not doing a lot of like cardio, et cetera. So you could use things like that too to guide it.
All right, I want to be courteous of time, so we are out of time, but I'm sure Dr. Watkins will be happy to answer questions on the app, or you can probably find her while she's having some coffee, too. But thank you, Dr. Watkins, for a great talk. We're going to start the next talk in about 7 minutes, 8 minutes here, so if you guys are going to the workshops, you guys can transition over now. Otherwise, we'll have Dr. Nirav Pandya talk to you guys about youth sports.